For people who don't know me, I'm Sandra Kirby. I'm the Chief Executive for Rural Women New Zealand, a role that I've been in for, nearly 5 months now. I'm getting to be quite an old hand. And it is my absolute pleasure tonight to host this sharing shed and to host a former colleague and longtime friend now, Dr. Melissa Davidson. Sharing Shed, we are able to deliver because of the support of the Ministry for Primary Industry. So we thank them for their support, their ongoing support for Rural Women New Zealand and enabling us to connect people around the country. Melissa is a physiotherapist by training, a doctor in physiotherapy, although her doctorate was combined with the engineering school in Auckland. So I'm sure that at some point tonight we will find out why engineering works alongside physiotherapy. But her interest has been in pelvic health and pelvic men's and women's health, because men have pelvises too. Tonight we'll probably focus more on women's health, but if you've got questions about men's pelvic health, then those can come up too. Your questions will come up in the chat and I'll be able to see them. If you've got questions, they will supersede mine. But in the meantime, I'm going to get Melissa to start with just a bit of tell us a bit about yourself, Melissa. Where did you come from and what took you to physiotherapy school?
Right. So I decided when I was 15 that I was going to be a physiotherapist. I don't know why. I'd never seen a physiotherapist at that point. I just decided that I think I had a friend whose mother was a physio and she was pretty cool. So I thought, well, there you go. So I graduated in 1990, which is probably before most people have been born on the webinar, though there's some people who are slightly older. And I have gone through different stages in my career, always been interested in pelvic health and especially women's health. In my undergraduate, I was a physiotherapist at National Women's Hospital, saw some births, treated a lot of problems from those births, and I've just continued that. So over the years, I've done postgraduate qualifications. I've got my master's from Melbourne University and my PhD from Auckland University Bioengineering Institute. So I was the only clinician in an entire building of bioengineers. So yeah, so I'm considered rural, and I see lots of rural ladies coming in, and they often drag their husbands in because guys tend not to look after their pelvic health and won't tell you until the last minute there's something wrong going on. And we often see the kids coming in as well because, they're either constipated or they're bedwetting after being not bedwetting and that sort of stuff. So we deal with that kind of stuff as well.
And before we get into some of the technicalities, talk to us about being a physiotherapy specialist. There are about 20 physiotherapy specialists in New Zealand.
I think we're up to 22 now, out of 5,500. And I'm the only specialist in pelvic health. So I went through, I like to call it a colonoscopy and a gastroscopy without anaesthetic, is how you go through the rigmarole of going through specialist titles. So you have your general scope of practice of physiotherapists, and then you have an advanced scope, which there's only a few of those because it's a newer scope. And then we've got specialist, and you've got to meet all the competencies of a normal physiotherapist, but you've also got to be involved in research. You've got to be a leader in your field and leader in, nationally on a lot of other things, as well as clinical experts. So I've been a specialist coming up to 10 years, and the only one in pelvic health in New Zealand. I think there's around about 10 in Australia, maybe, I think. And in New Zealand, we're quite different from the rest of the world. We are under our registration authority. So that's the only place in the world that is under the registration authority that our scope of practice is defined as. So it makes us quite unique in New Zealand and around the world. And I think I'm the only one in New Zealand with a PhD and a specialist title. Or an advanced or anything else. So there's not many of us with PhDs in pelvic health. Let's put it this way. I think there's one other. There's a few other masters, but it requires a bit of, you don't have to be super bright to do it. You just have to be very tenacious and a very understanding family. Yeah.
But tell us what so somebody could come directly to see you,
Yep.
but they might also they might be referred from another physiotherapist or for a second opinion or something
Yep.
like that.
Yeah. So you can access physiotherapists in New Zealand without a referral from anybody. So we've had direct access since the 1980s, I think. I think it's around 86. And so if you're injured or if you've got questions or concerns, you can come straight to physio. Same with specialist physiotherapists for private. If you are under ACC, then there's a different protocol that they have to follow. They have to be referred by another physiotherapist or a GP or a consultant specialist like an orthopedic or a musculoskeletal specialist under ACC. I only see private patients now, so you can access me wherever. And I think my furthest patient from overseas was in Scotland. I've had somebody fly here from New Caledonia to see me, and we have people around New Zealand coming to see me to Kinloch, and I think they use it as an excuse for a holiday. And we also do online, obviously. So with post-COVID, online is a lot easier and a lot of more people. It makes access much easier, so we can access patients and they can access us. The other thing that's changed, well, I see patients clinically, but I also train health professionals. So I don't just train physiotherapists, I train gynecologists, GPs, medical doctors, nurses, nurse specialists, osteos, etc. On pelvic health. So they can learn how to assess a vagina correctly, for example, or a pelvis, or if you've got prolapses, how to, I train them up on how to fit pessaries. So that's part of what I do. And the other part, we've just launched a week ago courses for women around prolapses and what treatments are out there and what do you need to know about pessaries, because I'm very aware I'm 20 minutes from Taupo, so I'm not that rural, but you do think twice about traveling anywhere. And there's women who are, 3-4 hours away. And how are they going to access in between, feeding out, the kids dropping off, picking up the kids or homeschooling the kids? How are they going to drive 2 hours to see somebody? So trying to access as much information online as possible for them that's evidence-based. So it's not just some social influencer who has no idea what the pelvis is, instead giving evidence-based information to the public, as well as training up their doctors so they know what to do. So yeah.
That leads us nicely into, people often think of physiotherapy as where you would go if you've had a sports injury or if you've fallen over or something like that. What would lead somebody to go to see a pelvic health physiotherapist? What are the things that people come to you to say, this is what I'm dealing with?
Okay, so they incontinence, incontinence, so leakage of wheeze or poos, or wind, or farts, or like, for example, if you cough and you leak a little bit, that is common, but it is not normal and it's fully treatable. So success rate with physiotherapy alone, or it's considered conservative therapy, but success rate alone is around about 80%. So if you've given birth or you've hit menopause or you've gained weight and you're thinking, I used to be able to sneeze without leaking or cough without leaking, or you go to pick up your kid and you go, whoa, hang on, what's going on there? Or you have arrived home and as you've driven up the driveway, you're looking at the keys and you're going, I really need to pee. I really need to pee. And you're getting the key in the lock and it's just not working. That's when you leak. So that's incontinence. That's urinary incontinence. Fecal incontinence or bowel incontinence is where you lose control of your farts or your liquid or solids. So sometimes that's gut related. So, you might eat something that really upsets your gut and very, very quickly. I went through an episode where I couldn't have sandinosis very well. I was on the committee and I could not eat onions and garlic without having a significant reaction within, seconds sometimes, which made it very awkward if you're in a meeting and you're going, no, out of my way, got to get to the toilet because otherwise I'm going to explode, sort of thing. So when you're trying to deal with that sort of stuff, that's when you sort of come and see somebody like me. Prolapse is where your innards are falling out your vagina, or your vajayjay, or whatever terminology you like to use. So that's where you either get your uterus coming down the vagina, your bladder pushing back into it, or your bowel pushing forward. So if we look at, this is a model I helped create. It's the levator ani muscle. So we've got, this is the vulva, that's the exterior genitalia of a female, and that's the vagina. So about 50% of women don't realize vulva, vagina. I've taken away the bladder, it's here, and the uterus sits here, and the bowel sits underneath. So this is the vagina. Now, if the walls get really, these parts of the vagina, if you, for example, if you're giving birth to a child, we all know that the vagina kind of, hang on, I'm just going to use my hand. The opening to the vagina is kind of like, in there, okay? We don't walk around with it gaping. It's, except for immediately post-birth, I can still remember walking out of the birthing unit in Canada where I gave birth to our first boy, going, it feels like everything is falling out. And I had this great big surfboard pad on. Most of you would appreciate the surfboard pad and memories. The vagina is potential space, but when you give birth, it extends to 10 centimeters, which is about that. So it's the only muscle in the body, this muscle here, the levator ani muscle, that stretches over 300%. So a normal muscle, especially in guys, start tearing around 30%. By 50%, you're getting lots of micro damage. In women, we stretch it over 300%. Now, one of the birthing injuries that can happen is called a levator ani avulsion, where this part of the muscle rips off the pubic bone. So this is the pubic bone here with this finger, and it rips off. So it's not repairable. Once it's happened, it happened. But you've got the rest of the muscles. So it's not the end of the world. You've still got the rest of the muscles there, but that bit no longer is working. Now, if you look at that from a support point of view, this supporting bit of the bladder is no longer supported by the muscles. So it will push in a little bit. And that's what a prolapse is. So I'm not sure if you'll be able to see this. Oops, sorry, I'm working out the camera angles here. But if it comes down, you may well see something like that. Okay. So it's where you go, okay, I can see something at the vagina, or it might feel heavy, or it might feel uncomfortable. It just doesn't feel right down there. Often it's a sign of a prolapse, either of the anterior wall, the posterior wall, or the apex of the vagina. And so conservative therapy for both incontinence and prolapse, first line of treatment is pelvic health physio. And we can make a significant difference. So it can improve things dramatically by reducing your symptoms either completely or at least by one stage, and improving the stage. Now, if muscles alone are not good enough or enough for it to work once we've worked your muscles, then you've got things like this. And this is silicone pessary. It's flexible, it moves. This is kind of like the size of a tampon, or this one is. And they come in all different shapes and sizes. And I've got a whole collection here. You can also make them into earrings. These are small ones, believe it or not. I've got a sample that I show my patients, which is about this big. It's huge. I've got an assistant passing me stuff. This is a fitting kit, and you can see the different sizes of pessaries in it, okay? And they are designed to be internal scaffolding for the vagina. So they go into the pelvis or into the vagina, very easy to self-manage, pop it in, it holds everything up, kind of like a sports bra. If you think about it like a sports bra, those of you who've hit menopause, you know that things go south slightly. You know, Your breasts that used to be up here are now down there. Your bingo arms are happening. Your butt used to be pert and now it's a little bit less pert, let's put it that way. And the same happens in the vagina. So around about 50% of women who hit menopause will have prolapses. Now, risk factors, lifestyle involving lifting. So if you're a farmer, and for example, in the Waikato, you're a dairy farmer and you're having that lovely joy of taking great big 20, 30 kg calves away from their mothers, and you're lifting them over the fence to get them into the other paddock or into the vehicle to move them up to the barn, then you're putting a lot of stress through your pelvic floor. And that's when often my farming ladies will prolapse. And they're going, well, why has it happened now? Often menopause, because menopause, we lose that protectiveness of estrogen in menopause. So some of the damage might have occurred during childbirth, but it doesn't come and bite us on our butt until menopause hits. So for those women who are giving birth, who are still young enough to get pregnant and give birth, it's really, really important. ACC now is covering maternal birth injuries of a certain types. And I've been quite involved in that process over quite a few years. And it's really important that if you're pregnant and then you give birth, that you keep your delivery notes. Really important, and you load them up into the cloud somewhere in a secure unit, cloud-based system, so that if in 30 years' time when you hit menopause and you prolapse, you can access your birthing records and you can say, I had a tear during childbirth. Your prolapse will be covered under ACC. Okay. It's designed to cover the long-term consequences of birthing injuries.
Probably a good point to point out that the maternal birth injuries cover from ACC is only for births that happen since
October 1st,
2022.
Yeah. So those of us who gave birth beforehand, we don't get ACC coverage in the majority of cases unless there was a treatment injury. But from October 1st, 2022, there's a whole list of injuries that are covered now. You just need to make sure they register them. And some, unfortunately, there's a lot of places that are not registering them. So if there is a good way of thinking about it is if the midwife or the gynecologist or the obstetrician or whoever it is picks up a suture kit, they should also be picking their pen up or their computer to go registering your ACC claim right then and there. Okay, it's really simple to do, and then you are covered. Now, midwives can only register perineal tears. So that's where a perineal tear is where you tear somewhere in the vulva area. Okay, so this is called the perineum. Sorry, my camera is completely opposite direction to what I'm doing. Your anus is there. Your perineal body is there. I'm going to give up. I'm going to look. Perineal body is there. Anus is there. And the tears normally happen down over to the side or down towards the anus. And you will be told a different grade. So grade 1 is a smaller one, grade 2, grade 3, grade 4. It's really important that they grade it correctly. And if you're not sure, hang on, they've spent an hour stitching me up. What grade have they given me? That's a significant grade normally. Or there's been a bilateral, or there's been something else going on that's taken them that long to stitch. An ACC claim needs to be registered at that point. If you're going, oh, hang on, I gave birth 6 months ago, nobody registered anything, it's not the end of the world. Go see your GP or your pelvic health physio. We can register it for you. We can also register lots of things that the midwives can't. For example, physios can register an avulsion because we're pretty damn good at figuring them out. And on palpation, we can feel in that muscle. Now, an avulsion normally can't be diagnosed until about 6 to 12 months. We need the time for the tissues to heal. So there's no point going at 6 weeks and going, I've got an avulsion, everything's falling out, or they think you've got an avulsion. It is too early because there's a lot of tissue healing to go on. And if you have given birth recently, allow that tissue healing to happen. Don't think, right, You gave birth at 9 o'clock in the morning. Lucky if you didn't labour all night and it just popped out really quickly. And you're on the farm at 10 o'clock. These muscles have stretched. If we allow them to be really, really flexible immediately after birth, you're more likely to prolapse later. So allow time to recover. It doesn't mean take to your bed and do nothing. It just means don't push your body. Listen to your body. And if your body's still feeling good, and you're thinking, I'm only 2 weeks or 3 weeks down the track, just think what's happening internally. Have I got full healing? And if you think about if you're an all black or a silver fern and you've ruptured your Achilles or you've done a big strain, they're not allowed back at a lot of activities until at least 6 to 12 weeks because of tissue healing. The tissues have to heal in the right way to enable that support to happen. So
I'm going to cut you off there for a minute because I think there's two things I probably need to say now. One is I did mean to say there was an R-rated warning. We are going to be talking about private parts and showing private parts. So I don't think we've lost anyone. So so far everybody's coping, which is good. I can't see any questions coming through. But talk to us about some prevention. Kegels, when I was a girl.
Back last century.
It was last century when I gave birth. You are quite right.
I had to put that one in, Sandra. I also last century as a girl. Kegels are very American because the doctor that said, oh, these are pelvic floor exercises, I'm going to name them after myself, was a male. And I'm thinking, well, actually, I'm a female, so I'm going to call them what they are. We don't call the first person who did biceps curl, Alfred. So it's pelvic floor muscle training, so pelvic floor muscle contraction. And yes, prevention. So if you are pregnant, you need pelvic floor exercises during pregnancy because I know from my research or my PhD, you will lose around 22% of your strength just because of the pregnancy. So we counteract that by working those muscles. You cannot overwork your muscles. It's a fallacy. You need a strong and flexible pelvic floor. You need to be able to contract them on and relax them. And so you can't, by working your pelvic floor muscles during pregnancy, you will not delay labor. You will not make it second stage harder, which is the pushing. You will there's no negatives to doing them during pregnancy. There's no negatives to doing them through menopause or as teenagers or anything else. There's one side effect for pelvic floor exercises, which is known, which is improved sexual pleasure. So most women go, I can put up with that side effect. It's one of those side effects which are pretty good. So, and what it does is it increases the muscle strength. Our clitoris, we know that the guys can't find it. So clitoris is just underneath the hood, but it comes all the way down the sides, whoops, wrong side, of the vulva as well, on the inside of the vaginal walls. So if you think about it, if your pelvic floor muscles are contracting and you are bringing the sides of the vagina in and they're bringing them in here, then your clitoris is going to be more in contact with whatever is penetrating, whether it's a dildo or a penis, whatever, doesn't matter, but it will bring it in, so it makes your clitoral stimulation better, okay? So that's this known side effect. How do you do them? There's different words that work for everybody else. Everybody. If you say to me, try and stop from peeing, Melissa, you need to pee, you're in the middle of nowhere, but there's people around you, there's no trees, tussocks or toilets, hold your pee in, I'm pretty useless. I mean, I've been doing this for 35 years, I'm still pretty useless at that. But if you tell me stop a fart, suck up a tampon, my latest favorite is, Sandra knows this is coming, clit to tits, thinking about bringing or nodding your clitoris, then I can work it. Okay, it works. But if you say stop from peeing, it doesn't. So there's different wording, and there's different wording for women and for men. So if you have got a partner, a male partner, and they're starting in their 40s to, have a little bit of an erectile issue, that they no longer as pert as they used to be, and they're starting to do a little bit of this, first treatment should be pelvic floor exercises. But if you say clit to tits for them, they don't know how to do it. Stop from farting is optional for most guys. They don't know about that much either. But they do know nuts to guts. So nuts to guts, or imagining walking into really cold water. The water's about to hit the testicles, pull them up. So they're different wording for males and females. So for us women, we need to focus on the words that work for you. One of the physios down south, she likes to say, zip the clitoris. Now, to me, if I think about zipping the clitoris, all I can think about is getting my clitoris caught in the zip, and it just doesn't work for me. Another one likes to suck up a blueberry smoothie. And I'm thinking, I don't want a blueberry smoothie in my vagina, but I'll suck, think about a tampon, sucking up a tampon. So there's different wording that works for everybody. So you got to figure out, you're going to go through the different wording. And the easy way of figuring that out is go to your bedroom or your bathroom, get naked, release the bottom half. You can keep your socks on. It is getting colder. And either part your labia, just part your labia nicely so you can see the entrance to the vagina, and have a look with a mirror and see what happens with your pelvic floor when you contract the muscles. It should, and let me see if I can do this, it should pull and pull it up. So it should sort of draw that in like that, okay? And if you're not seeing that, or you're sort of thinking, is it working or not, wash your hands, definitely if you've been in with the cows or the sheep, and wash your hands, pop one finger in if you haven't had babies, two fingers in if you've had vaginal deliveries. We all know why, things get a little bit wider. Then you will feel your squeeze around your fingers, and it will try and pull your fingers into your vagina. If you are flinging your fingers out, or you can fling ping pong balls out of your vagina, you're doing the wrong action, okay? You want to lift and squeeze, but your eyebrows shouldn't be going up, your hands shouldn't be clenching. You should be able to do it while breathing, okay? It shouldn't be this either. That is a glute bridge, and that's not my pelvic floor. So I can put my pelvic floor on now. You can't tell I've got it on, I'm hoping, and I can relax it, and it's done, okay? You can't multitask. I know we're really good at it, but you cannot multitask. If you're going to do a really good contraction, you cannot multitask. So don't try and do them while driving, because if you do a really good contraction and it's a good, strong one, and you're focused on it, you will drive off the road. And then you have to explain to some 20-year-old police officer what you were doing that you drove off the road for. So let's not do that. A bit embarrassing on the right side of the road. Yeah.
So talked a bit about childbirth or post-childbirth, talked a bit about menopause. You mentioned that children might want to see, there's sometimes that children or premenopausal or prepubescent
So
might want to see a pelvic floor physio.
Yep. So with the younger kids, it is toileting is a biggie, and they may have delayed going dryness or constipation. Constipation is normally the most common reason we see kids, and they may be going daily, but if it's a little brick or a scorched almond or little raisins or sheep droppings, they are constipated. So a poo needs to be soft, sausage-like, even, no wrinkles on it is the ideal poo. Secret weapon of physiotherapists around the world, or pelvic health physios, is chia seeds. So making a chia pudding, making a chia chocolate mousse. The chia seeds basically absorb the fluid and bulk out. And so they soften poos and make them more bulky so that they come through the system really nicely. Your gut is from your mouth to your anus. If you're just open with kids around it, if they're doing the picky eating stage, which of course mine never did, absolutely never did, still occasionally do it, except for when it comes to chocolate. They change their mind about chocolate. And our oldest boy loves avocados. Really? They're expensive. Go away. But if they're picky, then you hide it. So, the vegetables and the bolognese, most of us are really good at that sort of stuff. or the chia pudding, you blend it and you hide it in a smoothie. So it's really important to look at the kids' poos. Also look at how they sit in the toilet. A lot of kids don't like the ploppy noise or the splashback. So you either have them on the potty and you have a nice smelling thing in the toilet. Don't put the kitty litter in the same toilet what the kids use, because that can cause problems. Making sure they're not rushed, making sure they're drinking at school. There's a lot of problems with school toilets, so they don't want to go, so they hold on, and then they cause problems around that. So sort of with the kids, often I'm being a detective and getting all the background around what's going on, and it can be as simple as take the kid litter out of the toilet and they stop their fecal incontinence because they can go to that toilet instead of the other one. And you can see kids, if you watch them, they will grab their penis because they're very busy playing and they need to pee, but they don't want to go pee. So they hold their penis to stop from peeing. And then when they go, they leak everywhere. And my boys learned very early that if they made a mess in the kitchen, definitely, but in the bathroom, they got to clean it up. I didn't care if they were two; they still cleaned it up. They only had one accident each, but I've got some mums who will still be cleaning their kids up at 8 and 9. It's like, no, I think we need to train them to do it, and it's part of their toileting. So yeah, a lot of kids will have incontinence of urine, but the problem is their bowel. So we've got to sort the bowel out before we can start the pee out. For teenagers and young girls, it's sports. And unfortunately, with periods, the whole sporting environment is set up for males. We know that if there is a female coach or a female therapist or a female doctor or a female mama who's involved in the sport, the girls will disclose much more information to that team than they would if there's only males involved. And then they will get help. For example, gymnastics and trampolining have very high incontinence rates, very high. And yet we can treat that. They don't have to put up with it. Netball, her favourite is the mums returning to netball after having their first babies. And you can guarantee over half of them will be having pads on because they're leaking as they're jumping. We can treat that. It's treatable. It doesn't take a lot. It's not like normal physio where you go, a couple of times a week for 6 weeks or 8 weeks and you're fixed. It's like, no, you've got a 6-month period and I might see you 6 times in that time frame, maybe. And on my job is to guide you. My sister might say bully you. I would prefer to say encourage you, empower you to go the right way and go, okay, we don't want to take anything away from you, but we might modify things while your pelvic floor is recovering and then get you back to what you want to do. So if you want to lift calves, if you want to go and do CrossFit, or you want to do the mud run with your dog and the Waikato, I think every year in July they do that. And then that's what we're aiming for. We want to get you back to normal. And if it means, for example, that we need to get your pelvic floor working really well and also supply a little bit of extra support, then that's what we do. It's easy. Yeah.
Thanks, Melissa. We haven't got any questions coming through. So if you do have a question, remember to type it into the chat function. Otherwise, you'll get Melissa and my interest.
Well, I'll just keep gabbling on. Yeah.
Yes, and I'll keep asking my questions. I've heard you talk in previous times about your feelings about incontinence pads.
Yes. How to get
talk. Can I put you onto that particular hobby horse?
Yes, how to get a pelvic
Just a
health
little
physio.
leak.
Yeah. Just slap on a pad and go about doing your yoga poses on the tenor ads or whatever it is. When you need them, not a problem. But just slapping on a pad is kind of like putting a Band-Aid on a broken leg. It ain't gonna fix it. We can fix it. People have, oh, you've had a child, of course you're gonna leak. Oh, you've hit menopause, of course, you're gonna have prolapses. Just put up with it. You're a woman. No, we can do treatment for that, and it's not that hard to do, and we can get you fully functional. So it's like hormone therapy at the moment is going through a little bit of a pushback, as in there was that flawed study that basically took HRT away from women around the world because they said it was caused breast cancer. Well, it doesn't. And HRT is fantastic. I'm pretty sure my husband agrees with me on HRT on that because, you know, he just yelled out, yes. I've got headsets on, so I don't know if you picked that one up, but yeah, HRT, Ovestin in the vagina. The Ovestin is, oh, somebody's asked about the Ovestin. I've just seen it there.
Yes.
Yeah, that was that. I didn't actually look
Vaginal
over there.
estrogen cream is Ovestin.
Yep, yeah. So vaginal estrogen. So when you there's two main times that you use it. Postpartum if you're breastfeeding because you are low in estrogen then. And what happens is the vagina goes from a healthy, juicy peach to a dried peach, and it can feel like sandpaper. Same with menopause. As our estrogen drops, it can go like sandpaper. The tissues get fragile, thinner, less blood supply, certainly less lubrication, and quite sandpapery. So you may notice prolapses more. You may notice pain with sex. You do not have to put up with pain with sex at all, ladies. We can get you having whatever type of sex you like, pain-free. There's all sorts of things we can do around that. And that's not me watching you do stuff. That is me giving you advice and, you know, pointing you in the right directions. So a Vestin cream is very local. Now, a lot of them come with this applicator. I really should have saved an applicator because they're revolting, the applicators. They're this thin little thing. You screw it onto the tube and you squeeze the tube. It fills up a certain amount, and then you're supposed to shove that up your vagina. It's kind of looks like a pen, and you whack it up the vagina and you squirt it like a syringe for baby pain relief. And most people scratch themselves. They hate cleaning it. It can be painful and it's mucky because all of the Ovestin cream goes up the top, and then in the morning it all slides out, and you get up and you go, great, I've got a messy fanny. So alternative way to do it is measure on your applicator, put it on your finger and go, okay, it's about a centimetre. Right, I've got this sus. So that's your amount. And then you pop your finger up in the vagina as far as you can go. We know the receptors for Ovestin is in the first 2 to 3 centimetres. And you go swirly, swirly, swirly like a washing machine. And you bring it back and you put a little bit up around your urethra, which is just the little pee hole below the clitoris. You swirl it over there and you're all good to go. You don't get that huge mess in the morning. It gets the tissues that like it. You don't have that nasty applicator that nobody likes. And you get urgency often with menopause, which is when you really need to pee and you need to pee now. And that little bit of a Vestin cream around the urethra normally takes care of that really nicely. So, yeah. Now, some of the docs will say who haven't done a lot of menopause courses will say, you're on HRT, you don't need Ovestin. No. The topical works really well. Now, if you've had breast cancer, then there was, or you can't have Ovestin, talk to your oncologist because there's been some big studies out on repeat breast cancer versus mortality versus all sorts of bits and pieces. And the latest research on those is really encouraging for women to have topical Ovestin is normally good, but you need to check with your oncologist. So that works for that. Okay.
Questions are coming in now. Ideal time to see a pelvic health physio after childbirth?
If you're having symptoms before 6 weeks, like you're having incontinence, you just dribbling everywhere, you're getting a lot of pain in the area, you're not sure how to look after a perineal tear, etc., go whenever you need to. If you're not having a lot of symptoms and you're thinking, actually, I just want a pelvic floor checkup, then after 6 weeks. So that's when your bleeding's normally stopped. You can have I would love us to get funding for pelvic health physio during pregnancy. that would be the ideal. If we can stop the ambulance at the, no, what is it? Stop the patient at the top of the cliff and not be the ambulance at the bottom or whatever. If we can do prevention during pregnancy, we know that we can improve the outcomes of normally the labor and the delivery, definitely improve any incontinence during pregnancy or pelvic pain or anything like that. So if you've got the means to see a pelvic health physio while you're pregnant, do access them. They've got a huge amount of information. And then from 6 weeks on, unless you're getting symptoms, if you're getting symptoms, don't wait for the 6 weeks. Go beforehand so we can deal with those symptoms. You don't need to suffer. Especially when we have toys, we are quite comfortable normally holding a newborn on one arm while doing a vaginal exam and doing the rock. That does require a little bit of skill not to move the finger at the same time as rocking, but we do get it. Or I can give you a note saying that physiotherapy took 4 hours. If it didn't take that long, it only took an hour, for example. Normally my initial appointments are an hour. But I'll give you a note to say 4 hours so that your partner can look after the baby for longer and you can go to the local spa for a few hours, or just sit on the beach and taupo and breathe. So, yeah.
Now, there's a question here. We might split it into two. So what about getting up at night frequently to urinate?
Yep.
So would pelvic floor physio help somebody who had frequent nocturnal urination?
Yeah. So we look at your bladder diary, we look at what your fluid is during the day, what your fluid output is during the day, and what your strength of your pelvic floor muscles are. For example, I've just seen a lady who said, I'm trying to hold on as long as I possibly can, but I'm going so frequently. Well, she was going like 4 times a day and her bladder had expanded to over 1 litre. So she'd gone the opposite way. Often we get people going, I need to pee, I'll just go just in case. So with the Avestin cream, that helps with that. If you because sometimes the urethra gets a little bit irritated, gets a little bit scratchy, and that can lead to urgency. So that Avestin cream around that urethra can help with that, making sure that you're not having fluids that irritate your bladder. So the common problems are diet drinks with any of the diet chemicals in them, including diet products, teas, coffee, wine, beer, they can be irritants for some people. So the bladder diary helps us figure that out for you. And making sure that you're not drinking. Like if you go to bed at 10, we encourage you not to drink after 7. If you're going to bed at 10 and you're having, 500, milliliters of fluid, you are going to process that over about 3 or 4 hours and you will wake up with a decent pee. So we just got to look at, your fluid intake and output. And somebody's mentioned brain tumor involved with this issue. So that's bladder retraining. So we go, right, if you can pee and poo during the day and it's relatively normal and it's mainly affecting you at night, then we go, right, bladder retraining plus we want to look at your meds. Has the doctor got you on a special medication at night thinking that will disturb you less, but not realizing, for example, giving a patient a diuretic at night will make them pee all night because that's what a diuretic is for. And sometimes they forget the functional side of things. And we go, can they have that in the morning? They go, well, yeah, of course. And it's like, right, that takes care of the 6-time pees at night, and which leads to fatigue, which leads to a falls risk, and it can compound. So if for the older population, if you've got people who are getting up and down all night, we need to figure out why, and the detective hat back on, because that increases their risk of falls, hip fractures, and we know that over a certain age with a hip fracture, they're going to die within a much shorter lifespan. So we want to prevent that. So for pelvic health physio, prevention is really key. And a lot of the funding for our public health system is in mental health, cardiovascular, strokes, diabetes, cancers, the big ones. They're getting the funding. And yet the main treatment for most of those within regulation is movement and activities and getting you walking and getting you swimming and getting you biking. We know that it's more effective, for example, than a lot of antidepressants, getting you out exercising. And yet we don't have funding for pelvic health physio because if you're prolapsing or you're leaking, you're not going to go for a walk because it's too embarrassing. So we've got the main thing I have is removing the taboo around pelvic health. I will talk about pelvic health wherever I am, whether it's the supermarket, whether it's a dining room table. In fact, my kids have, I'd only found out last year, they have a running bet as to how quickly, if we sit down for dinner with friends or family or just anybody, does it take me to mention pelvic health? And what they've started doing is going 3 minutes, 1 minute 30, and they count if other people bring it up now as well. So, yeah.
I'm amazed that you've ever lasted 3 minutes without
I
mentioning it.
know. I was trying to be good on that time. But yeah.
Is it a myth that peeing after intercourse prevents bladder infections?
No, it's not a myth. What it is in some women, the urethra is really, really close, or the vaginal wall and the urethra are really, really close. So if you've had intercourse and there's been insy outsy sort of thing, that wall can get a little bit irritated. And then that then can encourage a little bit of irritability to that wall, which if it's irritated, bacteria are more likely to migrate there. And then they can go up into the bladder and say, hello, let's give you a UTI. So yeah, peeing after sex is good. And I have yet to find anybody who does not recommend that. If you've had regular UTIs, they're going, first thing, pee after sex. And making sure that you don't need to stick things up your vagina. You don't need to be revitalized, stick jade eggs up under the moon or wasp nests. Wasp nests were in for a period of time a few years ago where people would put in wasp nests up their vagina to revitalize it, or yeah, I know, laser wands, all that sort of stuff. The best thing that's fully researched, massive RCTs, which are randomized controlled trials and evidence on it, pelvic floor exercises done correctly treats a whole pile of stuff. And yet nobody talks about it because it's taboo. We've all got either a fanny or a penis, let's just get on with it, or a mixture. Some people do have a mixture. But we all wee and poo, otherwise we're dead. So let's move on and just go, let's talk about it. And the more we talk about it, the more we can get people help. I think one in 10 people will seek help for pelvic health issues. They won't even mention it to anybody. So if your healthcare professional's not asking you about it, tell them. Just get out there and go, yep, I leak with this. What recommendations? And if they don't recommend anything, get in touch with me. I'll recommend stuff. Yeah.
I know that when I worked at Physiotherapy New Zealand, we did some public research, and the people were likely to go the longest with pelvic health issues before seeking any assistance. So 12 months or more before seeking assistance. And I guess that if the message today is, if there's something that's not right when you wee, when you poo, when you have sex, or if it doesn't feel right down there, seek help sooner rather than later.
Yeah. The sooner we get onto things, the less miserable you'll be, the better functional you'll be. You'll be there for your family and your friends and that sort of stuff, and be able to do things that you want to do. Let's get you, my aim with all my patients is get you to fully function to the level that you want to do. I can't help you win lotto, but I can certainly get you back to what you want to do. And if it means, that you are in that sort of 10-15% of people who do need surgery for some issues, but that's a very small portion. The rest of it we can treat. And it's getting the right advice for your condition, getting the right assessment. And that's the other thing, is a lot of people don't assess the vagina correctly, unfortunately, or they just go for looking for pathologies and going, oh yeah, you're fine. Or you'll hear it all the time. You've had a kid or you've hit menopause, and you're a woman, just put up with it. I'm really for the no, we're not going to put up with it. I have had an interesting discussion a number of times in the local pharmacy around HRT restrictions in New Zealand. I've got a red flashing light now, I joke you not, on my record at the pharmacy. It flashes red at them to give me my full 3 months prescription. Don't even think about giving me only a month at a time. And I've had a standing discussion about how the fact that the HRT patches are not in the country, and yet honestly, we've got warehouses full of Viagra. And men can get testosterone cream, but women can't. And it's like, really? Come on, let's change that.
I just want to pick up one more thing because I'm very conscious of time, but we've talked about you being the only physiotherapy specialist in New Zealand,
Yep.
Pelvic health specialist, but there are other physios who work in the pelvic health area.
Yep.
So it's not that I'm not against you getting business, Melissa, but wherever you are in the country, there are pelvic health physiotherapists. Yeah.
And that's what I've spent I think we've trained, I think on last count, about 280 pelvic health physios in the last 4 years. And they're around the country, whether you're on the West Coast, whether you're in Gore, whether you're in Kaitaia. We've got pelvic health physios around New Zealand. Head to pelvichealthdirectory.co.nz. And that will list a whole pile. The other place to look at is Physiotherapy New Zealand. Put in find a physio for women's health. But the pelvichealthdirectory.co.nz, they have to be listed on that. They have to go through me, which means that they I want to see that they are doing internal exams. We want to make sure that you don't have to have an internal exam when you see a pelvic health physio. If you're thinking, yeah, nah, I'm over that, we teach you how to do a self-exam, but we are going to talk about it. And if you're comfortable, often people come and see me first and they go, oh, this is all you do? And I go, yeah. And they go, why? And I was like, well, because I can help people. And they get to know me first. And quite often we won't do the internal exam on the first appointment. And they'll get to know me and then we'll work up to it. Other people come in and it's like, just keep your clothes on while we're talking first. We'll just talk first and then we can do the exam. So there's a huge range. But the big thing is we have people who can treat you around the country. And if you can't find somebody time-wise and stuff, then most of us do online appointments and we teach you how to assess yourself. And then also if you're sort of thinking, I want more information, I want some reliable and evidence-based information, head to our website. We've got information on the website. We've got courses on the website for the public now. Brand new. It's a test run to see how it goes. Just trying to remove the taboo. The more people who can talk about it, that's why when Sandra said, oh, I think Melissa can have a talk with you, I was like, yes, please. I will talk to anybody and everybody about pelvic health because we need to remove the taboo around pelvic health because the shame and the embarrassment and the lack of health seeking because they put everybody else first. It's like, no, let's get you looking after yourself and living your full life, and I think we all deserve that.
Okay, Melissa, I'm very conscious that we said we'd finish at about 10 to 8 at 7:50 and it's 7:57.
We're doing pretty good then, Sandra, for us. Yeah.
Yeah, I think we did quite well. I suspect we could have gone for another hour or more. And judging by the fact that most people have stayed on the webinar, I think we've probably captured some people's interest. So on behalf of Rural Women New Zealand, Melissa, I do want to say thank you for your time. Thank you for giving up a Tuesday evening to talk about something I know you are passionate about, but also to share that passion and maybe help another group of women experience better pelvic health and live their fullest lives.
Yeah,
so
definitely.
On behalf of us all, thank you, Melissa.
You're very welcome. Okay, bye-bye, everybody. Any problems, just get in touch with me or look at the website for information.